I think it's important that I share my lived experience because it's quite easy to feel like you're alone when you're going through an eating disorder. It's it's very easy just to feel like you're the only one that's going through it when in fact there's so many of us that are going through the exact same thing. So the more that people talk up and speak about it, it's going to invite others, to do the same and hopefully instill that, hope within others, as they go along in their recovery journey.
A healthy relationship with food and body for someone is a very positive relationship with both food and with the body image. So for food, that means that they can eat what they like to eat, they enjoy their food, and they enjoy being with people while they're eating and enjoying all the social activities we have around food and eating, like at weddings or at other social events that people go to, or when you go out to the movies, the popcorn, for example. So they're not concerned about those things and they enjoy doing them.
I think it's probably the word that comes to mind is acceptance. It's accepting where your body is, how it's working, what it does, what it looks like. So again, it's a really broad concept. It's valuing your body for not just what it looks like, but things like I can walk, I can talk, I can lift stuff, I can move stuff. Like we don't think about that, but that's actually a miraculous kind of gift that our bodies can do. Whereas we're really conditioned to just be critical of it and have this almost semi-abusive relationships with our body, where really it's just something we can take care of, and and if we take care of it, it takes care of us.
If I eat normally and I exercise a normal amount, this is the body that I have, and it's for hugging and loving and it's for skiing and surfing and, it's for a whole lot of things, doing and sensing and knowing who I am. And my appearance is only one component of that and a relatively small one. So that when I'm free in my body and doing things, I'm actually not preoccupied with what I look like, I'm actually free to be in my body and to sense what I sense from it.
So it's really important to talk about eating disorders because I don't think that there's enough information or correct information out there that highlights the risk, the exposure, and the diversity of eating disorders as well. We typically have a very stigma approach to what eating disorders are, and living through an eating disorder, I can tell you now the effect isn't just on the individual, but it's on the families, the loved ones, that have to deal with it on a day-to-day basis.
With an eating disorder, a patient has a lot of anxiety around food and also their weight and appearance often. So in looking at food, they'll also be thinking about how that food is going to impact on their weight and shape and appearance. And often then they'll stop eating certain types of foods or quantities of food to make it impact on their appearance in the way that they want.
So the eating disorder affected every aspect of my life. There's not a part of my life that didn't affect negatively. My social life, so it affected all my relationships and it affected my family life, my relationships with all my family. It affected my work life. I struggled to go to work a lot of times. I had a lot of sick days. It was just really hard to be around other people. I gained a lot of weight due to the eating disorder. I had arthritis in my spine and that was obviously quite painful, especially carrying all that extra weight. It affected every part of my life negatively.
An eating disorder, through the anxiety that the person experiences, can really interrupt their relationship that they have between food and their body. It means that they really struggle to listen to the body's signals around food, about how much they need to eat and also how much they want to eat, and that can get confused with a lot of anxiety and worry about the effect that the food might have on their body, whether it's their weight or their shape or even their appearance.
An eating disorder causes a person constant and persistent distress in the way they're feeling and relating to other people and to themselves, and that is very often all around the food and body image. So again, as I said earlier, around food, so much of our life is centred around food, living with people, sharing food, sharing the family dinner at night, sharing social events. For many cultures, food also has a lot of significance. In certain traditional cultures, it may be the way of greeting people. Someone with an eating disorder can't do that easily, and they certainly can't do it without it causing them a lot of distress and concern. And that distress and concern starts to evidence itself in mental health problems. They often may become very anxious. They often become very depressed as well.
I guess so. The eating disorder started for me from, I think stress may have been a large psychological factor for me. And the starvation that came through that and the effects on my body, I started to develop obsessive behaviours. I was no longer sleeping. As I said, was very stressed out. I developed anxiety, although I was not sure what that was at the time. I felt like that was a part of me. And I guess during the depths of that and with these changes that came with the eating disorder, I believed that was part of me. And it's having the education now that realising that these were actually psychological effects that do happen when you do develop an eating disorder.
For a person with an eating disorder, there is a lot more going on than a simple decision about food. Some of the things that are happening for a person with an eating disorder include stress responses, a harsh inner critic, reinforced behaviours, personality traits that may maintain the eating disorder, social and environmental pressures, significant effort required to maintain or hide the eating disorder, and the effects of starvation on the brain and body. All of these things contribute to a sense of loss of alternatives where the person comes to believe that maintaining their eating disorder is the only thing that will work for them.
I was in my 20s when I started restricting. I was at uni, I was living independently, I was working, I'd had other mental health concerns before. So I'd always struggled a little bit to maintain my well-being, but when I started restricting and that kind of came in, things got very out of control very quickly. I couldn't finish my studies, so I had to drop out of uni. I ended up living with my mum. I went into significant financial not debt, but issue trying to pay for health insurance and trying to pay for medication and therapy and everything that goes along with recovery. And I think the biggest impact that I still feel is on the relationships that I have with people. I lost a lot of friends and important relationships because I felt so consumed by my thinking and behaviour around food and eating that I couldn't be the friend that I wanted to be to people. And I think after a while that gets difficult for people to bear.
It interrupts everything. It's an illness where your relationship with food becomes one that's fraught with fear and anxiety and terror and punishment. Food becomes so aversive. I mean, even at a brain level, when you have an eating disorder, your fear centres light up when food is presented to you rather than your pleasure centres. Eating disorders are the most non-discriminatory illness that you can get. Everyone can get an eating disorder. It doesn't discriminate on gender, which is one of the great myths of eating disorders. It doesn't discriminate on cultural background. It doesn't discriminate on socioeconomic background. It doesn't discriminate age. I certainly see my practice kids as young as 5. My oldest patient is about 80. It doesn't always just occur in adolescence. We often think about it as a disorder of adolescence, but it can occur and it can have onset in adulthood. Even something like anorexia, which we think of as a mainly adolescent illness, can occur. It's an illness that spans across the lifespan. It is the most diverse illness, I think, perhaps that there is.
So you miss out on a lot. I know for a fact I missed out on heaps. So there was, friends engagements and things like that I just went, no, I'm not going to. Family, the fact that it's not just I can't go somewhere and do something, it's I've lost all my strength. So I can't pick up my 8-year-old daughter to give her a cuddle. I can't carry you, I'm sorry. And as a dad, what's the one thing that you want to do with your kids, right? Is give them a cuddle, carry them, give them a piggyback, put them on your shoulders. So I've missed out on being able to do that purely because of my eating disorder.
In terms of medical comorbidities, the list is quite long actually, and there's a range of conditions that make you more liable to get an eating disorder. And one is, for example, type 1 diabetes mellitus, celiac disease, inflammatory bowel disease, anything that causes malabsorption or difficulty being able to eat all food groups, or that affects your chewing or ability to swallow food. So all of those things can lead to an eating disorder. So we always and our dietitians always encourage people to have the most diverse food they can have. There's no bad foods or good foods. It's all about just enjoying food and making it social, which is really the opposite way to what the culture's going, isn't it? About trying to cut out carbs and a whole lot of sugar and a whole lot of other foods. We'd encourage generally people to be inclusive rather than exclusive with their foods.
There's a massive impact. Every aspect of your life, that's social, mentally, physically. It is your life. The main one for me was probably socially. I skipped out on a lot of outings with my friends, I guess in my early adult years, purely because, that eating disorder voice, inside you is telling you, it's not the right decision to go hang out with your mates and go indulge, in good food and drinks and whatnot. It's telling you that the right option, is to go to the gym, late at night and, putting in that extra work, and it frames it like it's a good thing, that you're motivated and whatnot to do it all, but really, you're just missing out and you're making the wrong sacrifices. I think, for me, mine was around the age of 17, 18. So, those last couple of years of school. Year 12 was a real struggle for me. I missed a lot of school because of that, but it wasn't known publicly that's why I didn't want to go to school. I was always feeling very lethargic and down, and just not motivated about life.
Other ways eating disorders present are with problems with mental health issues. Very often people may be presenting with depression and anxiety, which are consequences or part of the eating disorder for them. And again, people need to be asked, if you're presenting with problems with depression and anxiety, to just ask and check out, have they also got problems with eating or body size issues?
It's hard because there's obviously a part of you that does want to go out as well. But it's not only the eating disorder that's kind of preventing you. It's now, I have social anxiety and depression as well. So, when those three things get together, it's almost impossible. There's so many, negative thoughts going through your head. There's so many barriers in just to get to a certain location to see your friends. And yeah, that's what makes it so difficult. It's just that mental barrier.
So it was the bullying that did make me to not feel good about myself. I remember going to school one day, not even thinking about appearances in anyone or how that made you feel as a person, and then all of a sudden being bullied by people for the way that I looked, which essentially then took a spin to change my life completely. So things rapidly spiraled out of control.
Groups that are at higher risk of developing eating disorders include people who are dieting or trying to lose weight, adolescents, people who are involved in competitive sports or occupations that emphasise body size or shape, women, particularly during life transitions, people with low self-esteem, anxiety, depression or problems with substance misuse, people with diabetes or polycystic ovarian syndrome and several other health conditions, people with perfectionist or obsessive-compulsive personality traits, and people from families where there is a history of eating disorders or disordered eating.
I guess my parents at the time thought that it would be helpful if we started to diet because they wanted me to fit in. They no longer wanted me to experience this bullying. So instead of going on something that was seen as a harmful diet, essentially turned into an eating disorder, which took over just took over at a young age and into my teens and 20s.
Well, we know that eating disorders are often very hidden, and people have often very great misunderstandings of what an eating disorder is. And the stereotype of eating disorders being a young woman with anorexia nervosa is probably because of that historical context, because that was the first eating disorder to be described, to be recognised, to be talked about by doctors, and to sort of get into medical consciousness, if you like, and then public consciousness has become the predominant image. But eating disorders occur across all age groups, and they occur across men as well as women. And one of the atypical presentations is becoming more typical these days is young men who are struggling with body size and body image issues, but they're wanting to build up muscles, so they're using steroids in very inappropriate ways. Other atypical ways are the people who have lost a lot of weight and are essentially in a starvation state, very similar to people with anorexia nervosa, but they're not underweight. So the doctor just says to you, well, you can't have an eating disorder because you're not underweight. In fact, they can have as severe as an eating disorder as someone with anorexia nervosa. They may have lost 20, 30, 40 kilograms of weight, for example, and be in such a severe state. And we call that atypical anorexia nervosa.
In my understanding of the trans-diagnostic view of eating disorders, which was developed by Christopher Fairbairn at Oxford, this idea that all eating disorders have more in common than they have differences. So if we look at anorexia nervosa, binge eating disorder, bulimia nervosa, they all have in common several characteristics. One is over-evaluation of shape and weight, and that being the main criteria by which a person judges and values themselves, and that leading to restriction, dietary restriction, and in some folks that leads to them getting a very starved brain and getting very obsessive, for example, people with anorexia. In other folks it leads to binging behaviours, and then sometimes purging behaviours. So it's this idea that eating disorders have more in common than they have in difference, and so you can also develop treatments that address those things. So the treatment gold standard is CBTE for all eating disorders. So there are some of the aspects of the trans-diagnostic model. Not everyone agrees with the trans-diagnostic model, but I think it is a useful starting point for all eating disorders. And it has this idea that we try to, for each person with eating disorder, try and understand what are the factors that are perpetuating and maintaining and getting them stuck in that pattern. And we try to address those with treatment with that approach.
The criteria have changed for eating disorders over the years. So in 2008, when I first got sick, I was very restrictive in my eating patterns, but I didn't meet all the criteria for anorexia nervosa. So I had what was then termed EDNOS, or eating disorders not otherwise specified. And then eventually moved through that diagnosis into anorexia nervosa, and then moved across to bulimia. And I think my recovery, my weight recovery was very different to my mental recovery. So as my weight changed, often my symptoms changed. I always had an eating disorder, but it expressed itself quite differently depending on where I was at.
People who are presenting with eating disorders are completely and absolutely unique. There are core kind of features to look for, but I always sort of caution about just sticking inside the box. There's a lot of people with eating disorders fall way outside these boxes. Like an example of someone with an atypical eating disorder is someone who just doesn't make diagnostic criteria, and often it's because maybe they're not binging quite enough to reach diagnostic criteria. So instead of once a week, it might be like once every 2 weeks. They may not have quite lost enough weight to meet some box that gets ticked. And so a clinician might be fooled into thinking, these aren't really important, maybe they'll just go away, they're a very mild condition. Well, they're not. There's actually no data to support that whatsoever. The level of psychosocial distress, comorbidity, impact on life is exactly the same for someone with what would perhaps be called an atypical eating disorder as someone with a typical eating disorder. And the problem with the idea of atypical or subclinical or almost an eating disorder is when we're rigidly following boxes, which is what we try and help our patients not do, when we're rigidly following boxes, these group of people get missed in terms of access to treatment, which is a travesty.
When I try to train clinicians about eating disorders, I always try and help them understand what causes eating disorders. How do you catch an eating disorder? So people don't choose to get an eating disorder, but there's a combination of factors that often lead to them. By far the biggest risk factor is dieting. So if you have two teenage children, for example, and one goes on a diet, she's 18 times more likely to develop an eating disorder. That's by far the biggest risk factor. And that's because dieting, especially extreme dieting, leads to changes in the brain. We know that from the Minnesota semi-starvation study done by Professor Ansel Keys in the 1950s. And what he found was that if people restrict their diet, their thinking changes. They become very obsessive, very rigid in their thinking about food a lot of the time. They become depressed, anxious, and they get very focused on the detail, what we call proofreader thinking. They lose the ability to stand back and look at the bigger picture. And once you get in that starved brain, it's very hard to get yourself out of it because we all believe what our brains tell us. And so a big part of the treatment of eating disorders is to give people that education to understand what their brain's doing and that their brain needs regular nourishment so they can get back to flexible, insightful thinking. I like to have the parents or loved ones in the room too so they can hear it too and they can understand it. And one thing I sometimes just write on a bit of paper first is, I said, read these words, "It's not your fault." And often there's tears at that point because and I said, willpower's not going to get you better. You've tried willpower, you know, whether they've got binging, purging or starving, they need to re-nourish their brain. That's the first step.
Starvation does make things complicated. Just telling someone to eat more when they have a starved brain is not going to work. You have to understand why they find it hard to eat more. A starved brain leads to depression, it leads to obsessionality, it leads to decreased libido, it leads to kind of increased social isolation. In fact, all the features of personality that we used to think, well, that's the anorexic personality. No, that's actually just features of a semi-starved brain. But once you kind of know that, and once you know how that might make someone's thinking even more rigid, that might help you think, oh, right, so just trying to get them to change their thinking, which is really rigid pre-morbidly and now is really rigid because of starvation, maybe just asking them, is there another way to think about that, isn't going to work because they'll go, nope, there is no other way to think about that. And they're not being oppositional or anti in treatment. That's just a function of a starved brain. And actually knowing that actually leads to some of the complexity just dropping away a little bit.
The solution to that is the rule of threes, to have 3 meals, 3 snacks, and don't let your brain go for more than 3 hours without food. And so that's a good rule of thumb, and I explain that if people follow that for several months, we have a 75% cure rate, whether you've got anorexia or bulimia or binge eating disorder. And then I say, but most people find that really hard, and so that's why we have what I call a coach, which is often a CBT therapist, a therapist who does CBTE, or there's a range of other treatments that also focus on this, which is to help you just get back rehabilitating your brain.
We know from the research that if someone with an eating disorder has help and treatment early in the course of the eating disorder, that often the outcomes are 100% recovery and are very good. And that the longer the person has the eating disorder, it may be harder to engage in treatment, it may be harder to turn around, or it may just be it's going to take longer to turn around. And a big mistake is to think that a little bit of an eating disorder is maybe just a phase or something that will go away. In fact, intervening at that point very promptly can mean that it will go away. But doing nothing or leaving it or doing a sort of wait and come back in a year and see how you are, that can be far too long.
From a family's perspective, they go through a lot. They go through a lot of helplessness. They go through a lot of concern and worry because they just don't know what to do. The more information, the more knowledge, and the earlier that we can intervene, it's going to save lives.
There's also the facts that to help someone get better with an eating disorder, you need to address the medical issues, the nutritional and dietetic issues, and also the psychological and behavioural issues. So that's why it's really important to have a team, or at least clinicians who have an understanding of all those different areas. Having said that, I think there's a lot that all clinicians can do that can help them to get the person started on the right track.
Well, eating disorders are a mental health problem, so at the core of the centre of the multidisciplinary team is usually a mental health professional, such as a psychologist or sometimes a psychiatrist or sometimes a social worker with mental health training. And the treatment modalities are largely psychological therapies that we know are effective. So there will also be a physical health specialist as well in the community. That's very often the general practitioner or family doctor. In the secondary sector, that's often the paediatrician for younger people or an adult physician for older people. And as well, because for younger people, very often the core of treatment is around family therapy. There'll be a family therapist who may be from a different disciplinary background, maybe from a social work background, or from a psychology background, for example, or from a psychiatry background. The other core person, the dietitian, who's helping the person learn to eat normally and have a better relationship with food and eating. An exercise therapist may help the person exercise differently and have a better relationship with exercise and with their body and with movement, for example. The other core people are, because eating disorders have such an impact on people's lives and often do present when they've taken over the person's life, the person may have been living with eating disorder for 10 years or more, an occupational therapist or activity therapist to help the person work out different ways of living their life is very important as well. And finally, the really important person these days is a peer worker, someone who has lived the journey and can give the person with the eating disorder hope for recovery and how that journey may unfold to be living a better life.
It really is the experience of somebody else walking in front of you of going, you know what, I've been there too. And that is just the most reassuring thing you want to hear from someone when you're in the depths of an eating disorder.